Welcome to Deuk Spine Institute live stream spine surgery, Thursday, June 4th, 2026. This patient comes from Hawaii for problems with her cervical spine or neck. She has herniated discs at multiple levels, from C3 all the way down to C7, causing severe stenosis and compression of the spinal cord with damage to her spinal cord. She has a spinal cord injury. It's high cervical. She is still walking. She's still trying to live a normal life, but her arms are not working. She's got balance problems. She came here because we fixed her back on Tuesday. She had 2 herniated discs that were causing pain, and now today we're going to fix her cervical spine. You're going to watch the cervical, posterior cervical laminectomy and fusion, okay? And Dr. Patel is assisting me along with Luis. This surgery is done through the back of the neck. We have to make an incision from basically C3 down to T2. So I'm going to start by using a number 10 scalpel. Blood pressure should be systolic in the 80s to 110 max. Thank you, Dr. Berndes. She's asleep. She is chemically paralyzed with a muscle relaxant, and she's under general anesthesia. We've just made the incision. Now we're going to obtain hemostasis. What bleeds are little arteries located between the skin and the fat. The fat is yellow. You guys can see the fat. So I'm going to put a retractor in. The key to doing this surgery well, there's several things. One of them is you got to have a good assistant. I have a great assistant, Dr. Patel. He has a lot of experience doing these surgeries with me. Another thing, you need a great anesthesiologist, which I have, and a great scrub tech. So far I'm checking all the boxes. As far as a surgeon, you want to make sure that you come down on top of the spinous process. You got to feel it with your finger. Where's the center? And you got to come down right on top of the spinous process. If you stray to the side, you will end up going somewhere you never want to go, and you will hurt the patient. I need a little more relaxation. Hold on, Luis, almost there. Now you're going to go through this fascia right here. This is a posterior fascia. You can see it jiggling around because the muscle underneath it is contracting. When the muscle contracts, it pulls the fascia, so you get a jiggling, a dancing effect with the bovie. That means there's, to me, not enough muscle relaxer. I like to use a lot of muscle relaxer. We're using succinylcholine today. Cisatracurium, all right. Nimbex. So we're going through the fat. You see how yellow it is. If you have questions, by the way, please ask. This is a live stream. We're streaming on YouTube, Facebook, X, and LinkedIn. We live stream spine surgery because it provides an opportunity to teach. In this case, the public or spine surgeons who are watching. We get a lot of spine surgeons watching from all over the world. I get requests to train spine surgeons all the time, and right now we're just not set up to do that. I had a Ukrainian neurosurgeon wanting to come here last time we streamed, Tuesday. Thank you very much. At some point we may be able to do that. I feel for the Ukrainian people, but thank you for watching. All right, we're creating a little bit of smoke using this hot knife or bovie. I use a guarded short tip. It's very important now that we're on the spinous process. We're coming to the side of the spinous process. You want to stay right on the bone. We're doing what's called a subperiosteal dissection. Subperiosteal dissection means you stay out of the muscle and you stay right on the bone. I'm using a retractor called a Cobb elevator. Very important to understand that by using this Cobb elevator, I'm gently retracting the muscle laterally. Okay, and I'm peeling the muscle off of the spinous process. By the way, this is outpatient surgery. This patient's going home 2 hours after her surgery is done. So we want to be very careful with our blood loss. we want to be very careful with how we treat the muscle. All of the pain she's going to have after surgery is going to come from her muscle. Okay, so the more gentle I am with the muscle, the less pain she has. So I want to be ultra gentle. Any questions?
No questions.
Some of you may be wondering, Dr. Deukmedjian, why are you doing a fusion? I thought you were a laser guy, bipolar. Where's my bipolar pedal? The answer is yes, I'm a laser guy, mostly. Laser and plasma, that's what Duke Spine Institute's known for these days. But before I was a laser spine surgeon, I was a big-time instrumented reconstruction fusion surgeon, cervical, thoracic, lumbar. I trained at probably the best neurosurgical training program in the world at the time, back in the 90s and early 2000s. And we did an awful lot of instrumented fusion cases. Some of the first in the country. I was taught by the leaders in the world in instrumented spine surgery. Came out of my training able to do pretty much any type of spine surgery in the world. But over time, I found that the less invasive surgeries, patients enjoyed more, they did better, they recovered faster, we had great results. So we started doing less invasive. But if you go to our YouTube channel, Anthony will put a link in, you can look at the videos of my patients that I've done invasive fusions on, many of them with Dr. Patel and Luis here. And our patients are usually going home dancing after their fusion, not in the hospital, not on a morphine PCA like most other surgeons. They go home the same day and they're dancing. So check it out. See what I'm talking about. And it's a testament to the fact that these surgeries are done so many different ways by surgeons. Some of them know the right way to do it so that the patients recover quickly and have great results. Some of them still haven't figured it out. And honestly, a lot of it has to do with your training, how good of a training program you go to. Because you're only as good as your teachers. And if you go to a neurosurgery training program that doesn't have the best teachers, well, you're going to end up with not the best training. And there's not very many neurosurgery training programs, and most of them don't have the top spine surgeons there. Many of the top spine surgeons in the world are in private practice, like me, for various reasons, mostly autonomy. We like to have control of our practice, not have somebody else who happens to be the chairman telling us what to do. We like to do what's best for our patients, avoid political agendas, and just do what's best for the patient. Right, Dr. Patel? Good doctors always do what's best for their patients. Any questions? So far, so good.
Yes, we have a question from Keyboard Smash on YouTube.
Let me have, yeah, I'll get to it in a moment. Suck right here. Let me have a Raytech. So I'm done the left side, and what I've done here is I've peeled the paraspinous muscle off the spine in a subperiosteal manner, where I've cut through what's called Sharpie fibers, which are the fibers that connect the connective tissue of the muscle to the bone, Sharpie fibers. And I'm packing it just in case it bleeds, which it's not bleeding. We've lost about, maybe 5 cc's of blood so far. Now I'm going to work on Dr. Patel's side. I'm going to get some exposure there. Once I've done that, then I'm going to put some retractors in, and I'm going to finish my exposure all the way down to T2, okay, since we're going to fuse down to T2. I'll take the question in a moment, but it's important you understand there's many ways to do these surgeries, okay, and they're all wrong except for this way. And the reason I say that is I've had exposure to all the wrong ways over the years, and I've learned the right way. And if you study my technique as a surgeon and you do what I do, you'll be able to send these patients home the same day. Nobody else in the world does this. I'm literally the only spine surgeon in the world who does a posterior cervical multi-level laminectomy for amyotomy from C3 to C7 with instrumented segmental fusion on both sides of the spine using lateral mass screws, rods, and pedicle screws, and sends the patient home the same day. There's nobody else that does. And it'll take the rest of the world another 50 years to catch up. By then, these fusions probably won't be done very much. Thank God. People will be doing our laser surgery that we do. But for right now, there's many wrong ways to do the surgery that result in pain and suffering and complications. But we don't have those complications here at Deuk Spine because we do it the right way. I'll take the question.
Yes, the question from Keyboard Smash is, which muscle are you working on right now?
This is the multifidus muscle, right, Dr. Patel? All right, so I've gotten the muscle off of my side, and now I'm going to work on Dr. Patel's side. I'm down at about C7, T1. I haven't localized. I'm not using X-ray in this surgery. You don't need it. A lot of surgeons use X-ray for the surgery, but it's not needed. And they use it because they don't know the right way to find the anatomical landmarks to tell you where we are. But it's simple. All you got to do is find the C2 spinous process, which is the most prominent at the top, and then C1 above it doesn't have a spinous process, so you just have a posterior arch. So you can identify the C2 spinous process. It's huge. And then down below, you can usually find the transverse process of T1, and you know that that's T1, and then you see T2 as well. So I identify bony landmarks that are highly reliable, and you can verify them on preoperative MRI or CT, but there's no reason to do intraoperative X-ray. Now, some doctors like the intraoperative fluoro or X-ray because they want to place the hardware with it, but I don't find it necessary. And remember, radiation from an X-ray machine is not good. For patients, it's not good for the OR staff. So anytime as a surgeon, when you're operating on the spine, you can reduce radiation exposure to your staff and your patients, it's good. So I look for ways that safely reduce radiation exposure. Radiation is cumulative, meaning that it builds up in your body. The effect of it builds up. It's not the radiation itself that builds up, it's the damage to your DNA. And that creates problems, potentially, like cancer. Okay? You can also get cataracts, and you can get thyroid cancer. You can get bone cancer. So this is an occupational hazard for surgeons. We treat our patients because we love what we do. We love helping people, but at the same time, we take on personal risk. So it's important that you minimize that risk as much as you can in life. You want to minimize the risk to your team, to your anesthesiologist, to your assistant surgeon, but also to the patient. Okay, so not doing radiation is good if you can avoid it. So we're not using X-rays or fluoro, even though we have the best fluoro machines in the world. All right, everything's going well. You guys are going to start to see the spinous processes, the tips develop once I get the retractors in. Remember, I'm taking my time, and I'm staying on the bone, not going into the muscle. Going into the muscle would be very bad. That's going to cause a lot of bleeding, and it's going to cause a lot of pain for the patient. Dr. Berndes has the blood pressure absolutely perfect. Now, because she has spinal cord compression and severe stenosis, she is a case where we have to be very careful, not just with positioning and intubating not to over hyperextend her neck. But we also have to be careful controlling the blood pressure during the surgery. You don't want the blood pressure to drop until the decompression is done. If you drop the blood pressure before the decompression is done, you could end up with a stroke to the cord, which is then permanent, okay? Permanent paralysis. And in her case, possibly ventilatory dependence because it's a high cervical lesion. So we gotta maintain the blood pressure, which she's a very healthy lady. Not hard to do, right, doctor? All right. Any more questions?
Yes, we have a question from Chowovek.
Who?
Chowovek.
All right. How do you spell that?
It's CZOWIEKZ. It's Polish.
Ah, my Polish friends.
Yeah.
I think I know who it is. They love watching my fusion surgeries.
Chowovek on YouTube says, "Oh, hi. Finally a major surgery, of course. There's more blood loss than with minimal invasive techniques, but it's very cool to watch. I really enjoy watching your surgeries. Greetings from Poland."
Thank you, my friend. But you may have noticed there's been no blood loss. We've lost nothing. Skin knife. We've lost virtually no blood. I mean, we've lost probably 10 cc's of blood. Typically, with this surgery, when I do it, posterior cervical laminectomy infusion, I'll lose anywhere between 25 and 50 cc's of blood, 25 and 50. Most spine surgeons lose 500 on average for this type of surgery. So there's things that I do to minimize blood loss. And even though I do a maximal exposure. All right, I can feel the tip of C2. I'm almost there. So that's good news. Remember, you want to stay out of the muscle. Very important. Stay out of the muscle. If you stay out of the muscle, you will be rewarded with great results. Stay out of the muscle. But nice to hear from our Polish friends. I wish I could give you a better view. We have a GoPro, but I did not put it on. It's a lot heavier, and to be honest, I don't do that many of these cases, so I didn't think it was really warranted. All right, any other questions?
We have a question from Rick on YouTube.
Hi, Rick. Welcome to our stream.
Dr. Deuk, there is a doctor from Texas that does a procedure where he goes in and inflates the ruptured disc with a solution that's supposed to be very effective. It's called DiscSeal. Have you heard of this?
Oh, yeah, we heard all about it. DiscSeal does not work, in my experience. It does not work. It sounds amazing, right? It sounds amazing, but it doesn't work. We've had so many DiscSeal patients come to us. They spent $20,000, $30,000, $40,000 on DiscSeal, and they're still in pain. They're no better. The reason it doesn't work is not addressing the source of pain. Okay, yes, the disc is the source of pain, but it's not addressing the source of pain in the disc. Our laser procedure is the only treatment in the world that directly addresses the source of pain. All right, so I think, let me feel. She's got a deeper neck than I thought she would. So that's got to be C2 there. That's C3, 4, 5, 6, 7, T1, T2. So we've got the exposure we need on my side. We've had almost no bleeding. By the way, we call this exposure. That's what surgeons call opening the body up to see the area that you're operating on and fixing. It's called the exposure. Kind of think about a guy in a trench coat exposing, right? that we're opening not a trench coat, but the body. Look how little bleeding there is, folks. Huh? I don't know what, I'm going to keep using what I'm using. Yeah, it's going very well. She's doing great. I'm going to get to a cerebellar in a minute. Luis was asking if I want a cerebellar retractor. Any other questions?
Yes, we have a question from Charlie on YouTube.
Hey, Charlie. Welcome.
Sorry if you already covered this. Why did you choose a posterior approach rather than an anterior approach for this case?
Oh, that's a great question. Great question, Charlie. So the answer is simple. For me, first of all, I don't like doing any kind of fusion anymore. And I offered this patient laser, but I told her, I think the laser won't work. I told her that. I said, we can do the laser, but it's only going to have about a 60% chance of actually working to fix your problem, okay? I told her that. And I said the procedure that's going to have a higher success rate will be a posterior cervical laminectomy infusion. So I gave her the option to do laser, but I told her it's going to be less likely to be successful for you, just because of what's going on where your herniation is. Now, let's just pretend laser is not available for a moment. And all I'm going to do is recommend either ACDF, anterior approach, or posterior approach. I always do anterior approach when the patient's problem is 1 disc, 2 disc, or 3 disc. When they get to 4 discs or 5 disc, that's when I say we must go posterior. We must go posterior, okay? I think my loops, well, these are the proper loops, but I think I'm a little high on this stool. But it's better for the viewers to see. So I'm going to try to manage being a little higher on the stool to keep my head out of your view. Are you able to see what I'm doing, Anthony?
Yes, I am.
All right. So when it comes to cervical spine pathology with stenosis, disc herniations, spondylosis, I always go anterior unless there's 4 or 5 herniations that are problematic for the patient. So in the case of this patient, she has basically 5 herniations that are problematic. So I chose to go posterior, okay? One of them is really, really, really bad. The other ones are not as bad. All right, there is the fused C2, C3 right there. You can't see it, but I can. If you look at her MRI, you can see that C2 and C3 are fused together. Okay, you see that, Dr. Patel? C2, C3. We're going to have to take that and cut through it to decompress her. So I'm going to take just a smidgen more of the muscle off of the bottom of C2 lamina just to get better exposure. So if that's C2, C3, that's C4, 5, 6, 7, T1, T2. So it's a perfect exposure. I can see the T2. I'm going to use the bipolar. Luis remembers this is where you can get into trouble with bleeding because there are small veins or vessels that run between the between the spinous processes, especially at 7-1 and 1-2, 2-3. So I'm going to bipolar them first. They're veins usually, and they bleed like crazy. So the best thing to do is to bipolar them. And then I bovie them. All right? I hope I answered your question. But basically, I only go posterior when the pathology is multi-level past 3. 3 or more herniations. Okay, 3 or more herniations. 4 or more than 3. more than 3 symptomatic herniations. In her case, she has high-grade stenosis higher up, lower grade below, but it's more foraminal. So the problem is if I just fuse the upper cervical, the lower part is going to end up becoming symptomatic very soon. And she's going to come back and have more surgery. I don't believe in making people come back for more surgery. I think you should do the right surgery the first time so that people don't have to come back and have a second or third surgery. That's the right way to treat a patient. At least give them that option. I gave her the option of not having a fusion. But I told her eventually she'll develop a chin-on-chest deformity, kyphotic deformity, if we don't do it, which is true. And I've had patients, not mine, but other surgeons' patients come to me that had posterior decompression with laminectomy or laminoplasty, and they end up failing and coming in with chin-on-chest deformity. All right. Beautiful, Weedy. Can you guys see this? You know what, maybe
Oh, yes, we can.
where's Hector? I think I want to change out my loops. Have him come in. I want him to bring my other loops. The focal distance is just too short. I need a longer focal distance. All right, so that's T2. Now we're not going to decompress T2. We're going to just put the screws in at T2. So this is a very important concept for everybody to understand. If you're going to do a posterior cervical laminectomy infusion, always go down to T2. At least T2. If you have to, if you have osteoporotic bone, go to T3. But most people don't, and fixating down to T2 is enough. I'm going to put in pedicle screws at T1, T2, because I don't want junctional failure. I don't want her to fail at C7, T1. Let me know when Hector's here. Hector, I need the other loops. Okay? So, can you guys see in here, Anthony?
Yes, we can.
If there's no questions, Anthony, let's share with the audience the 30 different causes of neck pain. I'm Dr. Deukmedjian, CEO and founder of the Deuk Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Deuk plasma rhizotomy is the best treatment in the world available for painful facet joints. Deuk laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. I'm in the process, yes, tighter, of changing out my loops. And give me a second as I do this, folks. Make sure I don't contaminate my glove. All right, well, let's see. Am I okay?
Yes, sir.
Do you want to change the outer glove just in case? All right, any questions that you've seen our video? I'm back now with a different set of loops. Boy, I told you we need one in between. This is, again, the focal length is too far.
Yes, we have a question from Neil on YouTube.
Can you give me one more step up?
That between is in order, actually.
Huh?
It's already ordered. Hey, one more, please. One more step, please, right here.
Sorry.
No,
Nope.
no.
Has to go on top.
Not mine. Just like that. Yeah.
I'll take the question.
The question is, do you use intraoperative monitoring on a case like this? Is there a benefit to having that as a resource in the room?
Yeah, is that Neil you said?
Yes, Neil on YouTube.
Hi, Neil. Yeah, we are using intraoperative monitoring. We're monitoring SSEPs, MEPs, and EMG, but the EMG is not really something we're looking at because we've given a chemical paralysis, so there is no real EMG at this time. Okay, we're ready to do our decompression. Take this. I've done the exposure. It's finished. You guys can probably see. You want to zoom in so they can see everything?
Doing it now.
All right. Let me know when you're there.
I'm there.
All right. So we got the tip of the spinous process. We got the lamina. We've got C3 right here. It's fused up at to C2. So C2 and C3 are fused. I may need to do a little bit more exposure there. So 3, 4, 5, 6, 7. I'm going to be doing my laminectomy, no touch, with a drill down to here, C7. All right, I need to expose a little bit more at the top. Let me have the Bovie and Cobb. So yeah, we are doing intraoperative monitoring on this patient. So this patient was born with a fused C2, C3. All right, take that. Let me just see. All right. All right. We're going to get started, folks. I think I'm going to start here at the bottom at 7. So I'm using a 3mm neurobit. I'm going to go at the junction of the spinous, at the lamina and facet, spinal laminar line. Remember, this is a bicortical structure. It's got 2 cortexes. It looks pretty good. I can feel Dr. Patel is using a little bit of irrigation. How's she doing from an anesthesia standpoint? Kind of like being in the dentist's office, huh? Listening to that drill in your teeth. Your dentist doesn't drill your teeth? I can't see with your hand there. Let me see here. Suck there. Yeah. It's looking good. So 7, 6, 5. Let's go 4. And if you're interested, we do have some of these surgeries with GoPro footage. You have bone wax on a stick ready? My goal here is to disconnect. All right, let me in, Dr. Patel. All right, so that should be 3-2. Let me see. We got a little bleeder on the side, Bobby. Take. All right, I got to finish up this 3. Suck, suck. All right, that looks good. I'm going to come to your side. I need to disconnect my headlight. I need irrigation, big irrigation. All right, just leave the irrigation in there. I'm coming down. I'll need the step-ups. Who's disconnecting me? We're good? All right. All right. Coming in. So I'll need at least 3. That's probably good right there. I need the drill pedal on that corner, top corner, right? Perfect. Any questions, Anthony? While we get ready to
Yes.
decompress, do our laminectomy on the other side.
Yes, we have a question on YouTube from Ivan.
Hello, Ivan. Sure.
Hello, Dr. Deuk.
Hi.
Do you think the UBE surgery could be applicable?
Do I think what?
The UBE surgery could be applicable in cases like this.
A UBE?
Yes.
No.
Okay.
No. UBE surgery is not appropriate. I mean, I gave the patient the option of having endoscopic surgery, which is what UBE is. I think you have to ask yourself, what are your goals, right? What are your goals? My goal is decompression, a little bit of reconstruction, and stabilization. UBE, you can do decompression. Maybe you can get a little bit of reconstruction if you do some weird stuff. And you can also get some stabilization, but this surgery will take us an hour and a half to do, and we'll achieve all the goals. With UBE, you're going to have a higher incidence of not achieving the goals, and it's going to take a lot longer to do the surgery. So, I didn't even offer her UBE. I don't think it's appropriate. All right, just about done with the decompression. Don't push down on the spinous process. Just about done here. Uh-huh. All right, let's see number 3. Remember, don't push down, okay? All right, this is going to be number 3, which is already fused to 2. All right, let's just see what we've got. I think we've got the lower levels done. I'm going to cut the interspinous, supraspinous ligament between 7 and 1. I don't think I can cut it between 3 and 2 because it's fused. She was born with a fusion. She was born with number 2 and number 3 fused. There's her laminectomy. All right, can you see this? Try not to faint.
Yes, we can.
This is like the McRib sandwich from McDonald's, okay? You've got, gentle with the cord, you've got the C7 spinous process lamina, 6, 5, 4. I'm still missing 3, so I got to go get 3, which I expected. We're going to take that bone, we're going to process it, but first I'm going to stop some of the little bit of bony bleeding we get with the bone wax on a stick. Okay, so what's bleeding is the diploic bone right where I did my osteotomy. So I'm going to go down and I'm going to put a little bit of sterile bone wax, same thing the dentists use on your teeth for braces. And I'm going to stop this diploic bleeding. Then there's not a lot of diploic bleeding. It's mostly coming from epidural veins in front of the bone. But I want to do this just to try to get some extra hemostasis. Every bit counts. Right, Dr. B? But you can see how well decompressed the spinal cord is, right? Any other questions? Try not to suck the bone wax into the sucker, because then you're going to have a problem with sterilizing the sucker.
Yes, we have a question.
Right, Luis?
Yes, we have a question on YouTube from Tomake.
From who?
Tomake.
All right, my Polish friend.
Yes. I am not sure if you did not receive this question.
Here.
But have you ever operated on a patient from Poland, and what instruments will you use today? Stryker
Irrigation.
or Medtronic Vertex?
First of all, I have operated on Polish patients, yes, but not often, maybe one or two over the years. The instrumentation I'm using is, I think, the best instrumentation in the business. It's AlphaTech. Right? You guys are going to send me a check for $100 for saying that. No, but seriously, I have used it all. AlphaTech, in my opinion, is the best. I want you to notice, look at all the scar tissue here. All the scar tissue covering the dura over the spinal cord, okay? Because of inflammation. All right, we're going to take out C3 next. I need the Lexel. Actually, I'm going to take a drill first. I'm going to drill a little bit more of C3. So I've got to take a little more C3 lamina. I didn't go all the way down. I left the shell. And then I've got to crack it off. Fun stuff. All right. But I use AlphaTech when I do my instrumented fusions. Why? Because I've tried all the others and I think this company is the best. It's not the best service. I can't even stand the people who are in charge of AlphaTech. Okay, can't stand them. Don't like them. I get nothing from them, which I don't ask for anyway, because you shouldn't be. But just their implants are really good. All right. Yep, kind of what I thought. Let's see a Kerrison 3. Take that. I'll need you to suck, Dr. Patel, really carefully. Let me see. You may have a Kerrison 2. Let me see. This side's pretty good. Let's go to your side. I'm going to switch sides. By the way, this is the old-fashioned way of doing this. You use a Kerrison. I'm coming down. I'm coming to Patel's side. Put some irrigation. You have any betadine in there? Good. We have betadine in the irrigation. I'm switching sides. Let's go ahead and pick the drill pedal over to the other side. Any questions?
Yes, we have a question from Ray on YouTube.
Hi, Ray. Welcome.
If a patient has too small of disc space for a artificial disc due to congenital small disc on top of the degeneration, can the disc space be made larger by shaving to fit the artificial disc and hardware?
Careful with the cord. I don't recommend artificial discs ever. I don't think they should be put in. But since you're asking, you should not be putting an artificial disc in a patient with degenerative disc disease. It's a contraindication. All right, there's no purpose. Just do a fusion. Don't do it because patients want it. Do it because it's the right thing to do for the patient. Do what's always best for the patient, not what they want. If they want something that you know is not good, don't do it. Don't put an artificial disc in somebody who wants it just because they want it. Drill, irrigation and drill. So this is the hardest part of the surgery, what I'm doing right now. Because, drill, this is where the worst stenosis is, but also she's fused from C3 up to C2. So I can't just get rid of C3. I've got to drill somewhat into C2 as well. Yep, a little more, one more blast. All right. All right. At this point, I've got to, I don't know. I'm going to have to try and just use a larger Lexel. Give me a 3. You got a little kink here, so I'm going to have to try to remove it the old-fashioned way. Okay? Let me have the large bite. I'm going to bite off some of this bone mass here just to thin it out so that I can get the Kerrison in and do the osteotomy, finish the osteotomy. This is good bone graft right here. It's a nice piece of bone graft. Here you go. Look, yep. Okay, you got it? You can use that for grafting. I'm almost done with this decompression. I've had to change my strategy a little bit. How was she, Burndes? I've had to change the strategy because, here you go. You want this? Just about done. This is the way we used to do laminectomy in the cervical spine, thoracic spine using a Kerrison rondure. The problem is it takes longer, which is not good for the patient. But if you don't have a choice, you don't have a choice, and I don't have a choice. So I tried to do it with the drill, but it didn't work. So I got most of the spine decompressed. But are you seeing improvement by any chance in the SSEPs? You got improvement? That's a yes? That's great, yeah, because we've just finished the decompression. So we got an improvement in our waveforms for SSEP. Do we have any twitches yet? You do? How many? One? One twitch? All right, we're getting our motor function back because the paralytic is wearing off. Wow. Man, that is tight. Suck right along that. Just gently. Dr. Patel has worked with me for 18 years now, huh? Any questions? K4?
Yes, we have a question from Yaz on YouTube.
Yanis on YouTube, welcome. Are you looking in here, Anthony, at what we're doing?
Yes, I am.
Can you guys see this?
They can, yeah.
So I'm basically removing the lamina of C3 because I tried drilling it off at the spinal laminar line, but unfortunately it would not come off because it's fused at the top. C3 lamina is fused at the top to the C2, bottom of C2. All right. Go ahead.
Yeah, the question from Yaz is, which operation approach is the best if you have an OPLL? Is it PCDF or ACDF?
Yeah, OPLL is always best with PCDF. Always. Always, always, always best with PCDF. If I have any kind of OPLL, segmental or longitudinal, it doesn't matter. I'm going through the back. Of course, it depends on your surgical goals, but I would never go through the front. I mean, some people go through the front because they don't do a true decompression. They're just fusing. All right. Let me see where we're at here. Irrigation. We're just about done with this decompression. We've lost about 25 cc's of blood. Most of it's irrigation. Let me have a Woodson. I'm going to go in and check, make sure the cord is decompressed. Yeah, feels good. Feels good. Feels good. I'm not going to do any more. Let's see what we got. Gel foam soaked in thrombin. All right, we're going to put in our gel foam soaked in thrombin just to get some hemostasis here with the epidural veins. I'm actually surprised how deep her neck is, to be honest. I thought she had like a shallower spine, but she's pretty deep. Not the deepest I've ever done, but certainly not the shallowest either. This is gel foam soaked in thrombin. I like to put it on top of the dura. It's really good for stopping the little vein bleeding that you get. So remember, in surgery, it's very important as a surgeon to understand where the bleeding is coming from. If you don't understand where the bleeding is coming from, you will never stop the bleeding. Or you get lucky and you might stop it. But generally, you're not going to stop it. So you must know the different bleeders. You have the veins on the surface that bleed. Where's my cotton? You have the, and that's what the gel foam treats. Then you have the bony bleeding, which is your diploic bone. Gel foam doesn't work for that. And you got muscular bleeding, which is Bovie bipolar. The veins are also Bovie bipolar if you really want. All right, we got our hemostasis. Very nice, very nice. And now we're ready to put our hardware. So, Dr. Patel, the way I do hardware, folks, I'm going to put in what's called lateral mass screws from C3 to C7. I may go segmental, I may go every level, or I may skip. I have to look at the bone and figure it out. How long is this? You're sure? Let's measure it. We're going to, this looks longer than 14. Bring me a tape measure. Okay, it's very important that you always double check. And that is, all right, 14 millimeters. And we're going to use 14 millimeter screws. So this should really be 12 millimeters. Wait, do we have a 12 millimeter guard or not? I want the 12 millimeter guard. I'm going to shorten the length of the drill bit that goes into the bone by 2 millimeters. I like to put in 14 millimeter screws, but with a 12 millimeter guard. So I want to put a pilot hole, it's called a pilot hole, 12 millimeters, and then put a 14 millimeter screw. So the tip of the screw captures some extra bone. Plus I'm going to leave the head high so that it remains polyaxial. It moves to receive the rod properly. Now push this button here. That's forward. This is 12. Let's get the tape measure. Let's measure. Any questions? That's perfect.
Yes, we have a question from Charles on YouTube.
Okay, give me a second. I'll take it in a moment. Let's suck here. I want to see the lateral mass. Perfect. Yes, Charles.
What is the post-op recovery of the surgery, and is it painful?
What is the post-op recovery, and is it painful? The answer is yes, it's painful for sure, but less pain when I do this surgery than other doctors. And the recovery is 2 hours. She's going to go home in 2 hours. Now, some of you may be saying, Dr. Deuk, you're drilling blind. Why? The answer is it's not blind. I know exactly what I'm doing, but I'm not using an X-ray. That is correct, because I don't believe X-ray is necessary. Remember we talked about that earlier. All right, I need 14. Take this, don't let it fall, 14. Now when you drill these pilot holes, top, we always put the pilot hole and the screw 20 degrees out, 20 degrees up. Okay, that's the safe place. You stay away from the vertebral artery, and you stay away from the, how do I disengage? Here? No? Oh, and then turn? Is this a new set? Let me have the cob. I want to make sure the head's polyaxial. Yep, it is, good. Polyaxial allows, you know, in the old days when I started my residency, they didn't have polyaxial screws. This guy named Mickelson invented them, orthopedic surgeon. He's a billionaire now. Made a lot of money. But we used to have to bend the rods to the screws, and it would take an extra hour to do that. So what he invented was amazing in that it allowed the surgery to happen an hour sooner, shorter. It was incredible because he basically created screw heads that could receive a rod anywhere. So you didn't have to bend the rod perfectly, and you didn't have to twist the patient's spine. Because if you're going to not line up the rod with the screw head, you're either going to have to pull the spine out of position, or you're going to have to pull the rod out of position or the bone out of position. This is I'm supposed to get a 16. So it's 14s and 16, yeah. So I put in 4 14s on the right. I skipped C4 because I can't get a screw in there. So I did 3, 5, 6, 7, T1 and T2. Any questions? The trajectory is different for the pedicle screws. It's more straight, and it's more down instead of up. The tip goes straight and down to get into the pedicle. All right? In case you didn't know that.
Yes, we have a question from Rick on YouTube.
Rick on YouTube?
Yes.
All right, Rick, I'll take your question.
Why are artificial discs not a good thing in your opinion?
Why? Why would you do an artificial disc? What are you treating? Is a hole there? Is a hole there? What are you treating, Rick? What are you treating with an artificial disc? Are you aware of our signature procedure here called the Deuk laser disc repair? That's what you should be doing, not an artificial disc. The Deuk laser disc repair repairs disc injuries, whether it's a degenerated, ruptured, bulging, herniated disc, degenerated disc, spondylitic disc, it doesn't matter. Our procedure, the Deuk laser disc repair, is the future of spine surgery. No more artificial discs, no more fusions for degenerative conditions, no more procedures that don't work or cause more problems. Fusion, artificial disc, laminectomy, discectomy, UBE, everything has tremendous downside because it either doesn't work or doesn't last or creates complications. All right, I'm not able to get this 14 in. Let me re-drill that hole. I need the drill. Dr. Patel, can you move that muscle gently, very, very gently? I may need a tap. You guys have a tap? I think I just didn't drill it enough. Let me try one more time and have a tap prepared. Let me have the screw. I'm going to try one more time without the tap.
14.
If I can't get it, I'll need a tap. This is just very hard bone. There's no reason to have an artificial disc ever. They're passé. The next generation technology is laser surgery that I perform. That's what everybody should be getting, not metal in their back
14.
or neck. Now I'm doing this case with metal because she didn't want the laser, which is fine because it had a lower chance of successfully treating her problem, which I told her that ahead of time.
14.
But she chose this surgery, and I think this surgery is reasonable. So I did it. That's why I'm doing it. Hey, this is mounted improperly. You got to mount it properly. You're cross-threaded. You understand? Don't hand me a screw that's crooked. All right? It's very important. I may need the tightener. Actually, grab me a tightener. Berndes, I've got 20 minutes left, 25 maybe. Let me have the lateral mass screw driver, the one without the coupling. I want to tighten one of these lateral mass screws. While you're looking for it, yeah, thank you. Just going to tighten down this one screw. I left it too proud. There we go. See, it's a different screwdriver. It's T-handle. Let me have a 16, 2 16s, and we're done. Then I'm going to take the template. We've lost about 30 cc's of blood this whole case, guys. 30. I typically will do these cases with 25 to 50 cc's of blood loss. Okay, you see that? And I have some secrets as to why I'm able to do it with so little blood loss. Any other questions, by the way?
Yes, we have a question from Charlie on YouTube.
Hi, Charlie.
During a recent video, you mentioned something about ligamentum flavum
Let me have a
removal.
Bovie. Hold on, Bovie. I've got it. Go ahead.
During a recent video, you mentioned something about ligamentum flavum removal for decompression endoscopically.
Yeah.
I don't recall all that you said. Could you explain?
Yeah, I said that it's the wrong procedure. All right, we're done with hardware. I'm going to put my template now. I need to line up the heads and give me the template. Dr. Patel, line up the heads, please. Carefully, very, very carefully. Template. I said that the ligamentum procedure of removing ligamentum flavum, in my opinion, is not a good procedure. This is the template? This is really hard. Dude, I would not reverse her right now because if she comes out of pins, it's going to suck. Let me have the actual rod. Dr. Patel, you ready to cut this thing, or Luis? All right, so I'm going to cut the rod, but I'm going to cut it a little bit long. Oh. Where's the hole? Go ahead. Yep. All right, now I need a bender. I'm going to place this rod to connect all the screws. This is called a rod. I have to contour the rod first, and I want to contour it so I give her some what's called lordosis. Lordosis is curvature. I want her to have a nice, beautifully curved spine, back to the normal curve. To do that, I have to give her some lordosis. It's very complex bending. You have to do it perfect. Let me see. I may have to bend this down a little bit. What's your name anyway? Our Alpha Tech rep. Evan. Yes. Evan? Yep, Evan. Where do you normally work? Rod cutter? Advent. Who do you work with? I've heard of Dr. Alvarez. Is he a neurosurgeon? Ortho. Oh. Go ahead.
Yes.
Which school did he go to? Mm-hmm. Miami? Miami. Who does he work for? Advent? Works for Rothman? All right. You gonna go tell him what you saw today? I need to cut it a little more. It's always good to cut the rod too long, because if you cut it too short, well, now you're buying another rod for $800. Go ahead. But that's not my price, is it? Just kidding. These rods are expensive. I don't even know that I want to know how much it is. All right. So I've got to get it just right. Seems like it's still a little bit too long. All right, that's fine. That should be good right there. Last cut. Last cut. So what kind of cases does Dr. Alvarez do?
He does a lot of ACDF,
Yeah.
some PCP,
Which hospital? Or is that in, where is that located?
It's close to downtown.
Oh, okay. Winter Park? Nice. I think I live close to that. All right, let's see here. So I've got the rod the right length at this point. You want it a little bit long on the ends. And I'm pretty happy. Well, I may have one more cut. I think I lied to you. I have one more cut. Just a tiny bit. I really want it perfect. She's Hawaiian. And she's traveled far. I need the bender. I'm going to bend it just a little bit more. This is the boring part of surgery, folks. Sorry, but I can't make it any more interesting than it is. When you bend a rod, you never want to bend it all in one spot. You want to make your bend over a large length as possible. All right. That looks... You guys have a reducer? Yes, sir. Set screw? All right, here we go. These are the set screws. I'll show you guys one of them. Can you see, Anthony?
Yes, I can.
Set screw.
Mm-hmm.
Basically, it's gonna lock the rod to the tulip, to the lateral mass screw. Wait. Let me have a pickup. Not that, the other one. This one. I'm using these. Yep. Perfect. Good. I like that. Set screw. Now, not every surgeon does this surgery the same way I do it. Everybody has a little bit different technique. That's why no two fusions are ever the same. Let me have the holder. You guys have a persuader, reducer, persuader, whatever. Rocker. Not yet. Give me a set screw. So the way you put these screws in, it matters the order they go in. If you don't put them in the right order, you're going to struggle. And struggling is never good when you're instrumenting over the open spinal cord. It should be effortless as much as possible. All right, perfect. We did it. So our set screws are in place. They're not cross-threaded. Our rod's in place. On the right, we need to put the rod on the left. Any questions? Why don't you show this audience, Anthony, the Deuk laser disc repair versus all other treatments, since we're talking about that. Why not do artificial discs? Let me show you why. You have that video loaded? I'm Dr. Deukmedjian, CEO and founder of the Deuk Spine Institute. I'm here to talk to you today about neck pain and its common treatments. Neck pain has different causes. The most common cause of neck pain is a herniated disc. Herniated discs account for about 85% of chronic neck pain. The second most common cause of neck pain that's chronic is the facet joints. There are facet joints on both sides of the spine, left and right. There is one facet joint for every disc. Facet joint pain requires a different kind of treatment targeted at the facet joint itself. For disc pain, which accounts for 85% of neck pain, the best treatment in the world is the Deuk laser disc repair. It is the most advanced treatment that is the safest and has the highest chance of successfully eliminating symptoms. Let's talk for a moment about what's important for patients who are considering treatment for neck pain coming from an injured or damaged disc in their spine. The most important thing for patients, number one, is getting rid of their symptoms. The type of symptoms that disc herniations or disc injuries can cause include neck pain, headaches, and symptoms down the arm, such as weakness, numbness, tingling, or even pain shooting from the neck down into the arm. The symptoms of neck pain include disc herniations, which are the most common cause, and patients want those symptoms gone. That is their number one priority and goal. The second most important goal for most patients is to avoid a complication from the treatment. Medical treatments do have complications, and the more invasive the treatment, the more likely a complication will occur. Complications from surgery, for example, can include blood clots, pneumonia, heart attack, infection, failure of the spine to heal properly after surgery. There can be implant migration or implant failure, adjacent segment disease, and vascular complications such as injury to the blood vessels or nerves in the neck, including the trachea and esophagus. Nobody wants a complication from spine surgery on their neck, so less invasive is typically going to be a better option to avoid those complications. The third thing patients really want when they're looking at treatment options for curing their neck pain is they want a quick recovery. People want to get back to a normal life as quickly as possible. They want to go back to their activities, they want to be active, they want to play sports, and they want to go back to work. And finally, the next thing to consider is long-term results. For example, if you have a treatment today and it works, how long will that treatment last, and will it create additional problems down the road for you? Treatments like spinal fusion that are invasive typically result in the need for additional treatments such as pain management, physical therapy, and possibly additional surgery. We're going to look at each of these individually and go through each of these options individually. So we're going to start with more invasive treatments that are typically recommended for patients with herniated discs or degenerated discs in their neck. The most common treatment recommended around the world is anterior cervical discectomy and fusion. That is a surgical treatment where the entire disc is removed surgically through a large incision that is very risky. There's bleeding associated and risk of injury to surrounding structures such as the esophagus, trachea, and blood vessels in your neck. Complications are very common with this type of surgery. The complication rate is accepted at 48%, which is a very high number. So if you're considering ACDF or anterior cervical decompression and fusion, you are looking at a very high complication rate. The success rate of this surgery at eliminating neck pain is very low. It's somewhere on the order of 25%. That is the generally accepted success rate at eliminating neck pain. An additional treatment that you can consider is artificial discs. Artificial discs are very similar to ACDF. The difference is, instead of fusing two bones together with a metal plate and a cage, we're actually putting in a mobile disc made out of metal and plastic that moves. The problem with the movement is that these discs do pop out of the disc space. Over time, they can fail. They can cause collapse of the vertebral body above and below through fracturing, especially in patients with weak bones, such as osteopenia or osteoporosis. Those types of patients are at high risk for complications from both ACDF and artificial discs. Another complication from artificial discs is that you can develop facet joint pain and adjacent segment disease, very common with artificial discs and fusion, and they typically have the same rate of adjacent segment disease. There's also a long recovery associated with both ACDF and artificial discs. Recovery can take months to years, if recovery even happens at all. There's tremendous scarring in the wound associated with ACDF and artificial discs, lots of scar tissue, lots of pain, and lots of problems after these surgeries that are invasive. Alternative treatment would be to go in the back of the neck and do a cervical laminectomy and fusion. Again, large incision, high chance of complications, very long recovery, taking years to recover. All three of these types of surgeries, ACDF, artificial discs, and posterior cervical laminectomy and fusion, require the use of postoperative narcotic painkillers. Narcotic painkillers are opioids. They are dangerous. People get addicted to them, they can be abused, and people can overdose. It's easy to overdose on narcotics because you want to keep taking them to treat the severe pain you're going to have after these invasive type surgeries. The severe pain can last weeks or even months, and the addiction can happen very quickly. Let's move into less invasive treatments such as epidural steroid injections. This is a treatment commonly recommended by pain management doctors. They stick a needle into your spine and inject the steroid medicine to reduce inflammation. While this treatment can be effective at temporarily giving you relief for a few days or even a few weeks, the pain always comes back from a herniated disc because the source of pain is never being treated. The annular tear and inflammation within the annular tear is not treated by an epidural steroid injection. The steroid goes throughout your body and causes systemic side effects such as high blood pressure, elevated blood sugar. In patients with diabetes, this could put your sugar up into the 300s and 400s, which is very dangerous for patients. So steroids should be avoided as much as possible. Next, let's turn to spinal cord stimulators. The problem with spinal cord stimulators is they are highly invasive and they are frequently put into patients by untrained doctors who are not surgeons. These doctors are typically pain management specialists, and they're putting these stimulators in patients not because they can cure your pain, but because it's another treatment that they have up their sleeves. These treatments with stimulators pay these doctors obscene amounts of money. The profit for the doctor can be in the tens of thousands of dollars. Avoid spinal cord stimulators. They do not work, they're dangerous, they put you at tremendous risk, and in the end, basically you're taking this device, sticking it on top of your spinal cord and putting a pacemaker under your skin that you're gonna have to live with for the rest of your life. They cause scar tissue and they frequently migrate and get out of position. Next, we're going to talk about physical therapy. While physical therapy has many benefits, such as keeping you toned and fit while you're struggling through the pain and trying to stay mobile, but physical therapy will never, ever cure pain in the neck from a herniated disc. It will just try to keep you active and from getting more and more sedentary and developing deconditioning of your muscles because you're sitting around because you have neck pain all the time. Finally, let's talk about the Deuk laser disc repair. The Deuk laser disc repair is the solution for neck pain. If you have a herniated, bulging disc, extruded, ruptured disc, protruded disc, or degenerated disc, the Deuk laser disc repair works by minimally invasive treatment going to the back of the disc where the problem is coming from. This is the tear in the back of the disc that has inflammation, and using a laser that is extremely precise. The laser fiber itself is 0.5 millimeter or half a millimeter wide, and the endoscope allows me to see 1/20th of a millimeter. I can directly see the nerves and spinal cord It is an extremely safe treatment. As far as results go, the Deuk laser disc repair has the highest success rate of all the treatments we've discussed so far. We have a 99% cure rate of neck pain coming from herniated discs, and the Deuk laser disc repair has 0 surgical complications to date. Our patients have an immediate recovery. In 1 hour, they're leaving our facility and they're going back to their hotel room. They usually drive themselves in the next morning for a quick checkup, and then it's back to a normal life. Well, I've enjoyed talking to you, and thanks for taking the time to listen to our video. I'm Dr. Ara Deukmedjian. We'll also find this on our podcast at Deuk Spine Institute Podcast. Thank you. Welcome back. We've already put in the hardware, tightened it up. We've done our irrigation, and now we've decorticated. We're putting the bone graft in to the lateral gutters. Okay. This is the last stage of the surgery, is the fusion. I want you to notice, though, that fusion doesn't actually occur during surgery. We're doing what's called an arthrodesis, which means I'm putting bone graft and I did a decortication. So we do those 2 steps as a surgeon, but the patient is the one who actually has to fuse. And it takes about 6 months or longer to fuse your spine. They're going to fuse over the joints. Woody? They're going to basically, I drilled out the facet joints. They're going to fuse literally between the facets, basically through the facet joint. That makes Dr. Patel nervous because he's a facet lover. That's what he treats, facet pain. You got to put the bone graft down onto the bone, which is what I'm doing, pressing it down, pressing it down, pressing it down, so it's sitting on top of the bone where I use the drill to decorticate. Any questions?
Yes, we have a question from Tomake on
Tony?
YouTube.
Sure.
Are there any radiologic technologists in the room, or
Yeah.
just one? I've been an official radiologic technician since March.
Yeah, we do. We have Jordan here somewhere. Yeah, yeah. We have Jordan. Jordan is our technician. All right, go ahead and do the expro. And I'm going to put some vancomycin powder. Vancomycin is a topical antibiotic. It's really good for fighting against staph infections. One of the reasons I never get infections in these fusion patients is I put topical vanc, 1 gram. This is 500 or 1 gram? We got a little bit of bleeder, hold on. Bleeder, hold on. Let's keep the needle away from my hand. Patel, needle away from my hand. Is that 1 gram or is that 500? I want half of that. So I'll just put it in half. Okay. We're going to use 500. The problem is using a full gram, you can get red man. Suck some of the blood, please. Right over the gel foam, but don't suck the gel foam. Just go to the most dependent place, which is right there, right by the bone. Yep. All right, good. We're going to put in our vancomycin, 500 milligrams. And this will stitch. Oh, drain? Yeah, we got to put a drain. This is a JP drain, Jackson Pratt. We'll take it out tomorrow. It'll drain tonight. You want to make sure you put the drain under the fascia. Scissor. You want to cut the drain to the proper length. You want to cut between the holes. So when you take the drain out, you can see if you accidentally sewed it in. Stitch, because you'll have a rip where the suture held the drain and it rips. And you don't want that. All right, now I'm going to close the fascia. This is the fascia, this thick white stuff. You never, ever, ever close the muscle. The muscle should never be closed. Let's connect that to suction probably, right? But don't put a gel foam over the hole. Connect it to one of your suckers so we can suck any blood. So this is closing. This is the final stage of surgery. I've got about 8 minutes left, maybe 10. Are there any questions?
Yes, we have a question. Let's see. From
was I
Ray on YouTube.
Hi, Ray. Welcome.
Nice video. After watching it, I still have a question. After
Sure.
laser surgery, if the patient had cervical kyphosis and degenerative disc, is it herniation going to keep happening?
Yeah, great question. So if I did the laser instead, she would still have kyphosis, probably. She would still have a degenerated disc, but she would have no cord compression, no nerve root compression. The problem is I'd have to do 4 levels of laser, which is, you know, a long surgery, number one, but also lower risk of success because you're dealing with 4 levels, bilateral foraminal stenosis and central stenosis. So I just think this is a more of a sure thing. That's why I did not really tell her that laser was her best option. I said it's one of 2 options, and that you know, if it was me, I would do the fusion. That's what I told her. I personally don't like doing fusions anymore. I do them because my patients need them, but I do them because I'm good at it and my patient needs it. So, I don't know. Otherwise, I wouldn't do it at all. Remember, you never want to sew the muscle. We want to leave the muscle below the fascia untouched by the suture, because if you sew the muscle, you're going to rip it with the suture, and it's going to bleed, and it's going to hurt like hell for the patient. So you never want to sew the muscle, ever. And, you know, muscle is really an issue when you're doing surgery in the back of the spine, not in the front. There is no real big muscle in the front. You have the platysma when you're doing an ACDF, but that's a small muscle. This suture that I'm putting on through the fascia is a barrier to infection. And it also helps take some of the tension off the skin edges. Okay? So when you're doing the skin suture, or in our case staple, you're not going to have stretch marks afterwards. When you see people with an ugly surgical incision, it's because the surgeon did not take the tension off the skin. This is the part where you have to pay really close attention. You don't want to get the drain. See how the drain is right there? It's really easy to accidentally poke it, suture it in. I've never done that because I'm very careful. But I know people who have done it, and there's only one thing you can do. You have to take the patient back to surgery to take the drain out. So it's another surgery. All right, we're just about done. Any other questions?
Yes, we have a question from Ivan on YouTube.
Go ahead and cut those. Hi, Ivan.
Dr. Deuk, do you provide training opportunities for doctors from other countries? Thank you for your great work, vision, and answers.
Oh, you're welcome, my friend. And someday we will be able to train more doctors. We're just not able to do that today. But I try through these videos to do all the training I can and to inspire other doctors, patients, hospitals. I mean, we want to get the word out. There's a better way to do surgery, and we can lead by example. All right, so if you look here, I put some lines across the skin. This is very important at the end of surgery, where you got all these wrinkles and lumps. You want to look for the lines and bring them back together. And that's what I'm about to do. Dr. Patel, as always, thank you. It's a pleasure seeing you and being with you. I can finish this here. I think we're safe. Thank you, sir.
Thank you, everyone.
Thank you. I'll let you know when we have our next case together, okay? All right. Dr. Berndes, I got 5 minutes, but we still got her in pin, so we're going to have to keep her until, you could probably reverse her soon as long as you can keep her from moving. I mean, she'll still be weak, right, when I'm done? All right, any other questions?
Yes, we have a question from Ray on YouTube.
Yes, Ray.
Myself, I have cervical kyphosis and C2 are bulging and C5 is herniated. Looking at surgery options, based off of your answers, I would not be a laser candidate.
So Ray, here's the deal. You and everybody else out there, the best thing you can do is do a quick MRI review with me. I do it for free. I don't charge any money. I don't get paid. I lose money doing them. But I do it as a community service for people like you who want answers. The problem is you cannot make a surgical plan that's going to work on a patient, the best plan, based on an MRI report. That's why we do a review where I actually examine you and ask you questions about your neck, okay? Your answers to my questions during the exam is so important in making the right choice for the right treatment for you or anybody. You cannot base a treatment just based on an MRI. You're not going to get a great result. So I never base treatments based on MRI results. I base it on patient's symptoms and my exam. We call that exam the Deuk spine exam. So I can't tell you what you need done until I see you and I examine you on Zoom. So just do a Zoom call with me. It's free. All it takes is you getting us your MRI. And Anthony will put the link for that free MRI review in the dialog box so you can click on it, go to our page, and submit your MRI to me. It's been a long time since I put suture in. Right, Luis? We don't use suture for our endoscopic surgeries. We use staples. We just put 1 or 2, and that's it. But suture is needed for open surgery like this. Any other questions?
Ray said, my MRI disc is in the mail to you.
Oh, okay. Thank you, Ray. Thanks for the heads up. We will give you your answers. I promise you. I love meeting people on the MRI review and figuring out what's wrong and then giving them advice. I live for it. It's enjoyable. It's one of the more enjoyable parts of my job. Diagnosing what's wrong with people. I need 5 more sutures or 4 if you got them. You got them? So look at how we line up the needle exit from the subcutaneous tissue with this line right here, right? And then I enter the other side right where that line is too. So that way you get a nice closure of the skin.
Okay to run a motor function?
Yeah. Yeah, you She's actually going to a hotel. She's here with her son. He's a boxer. They're from Hawaii, Maui, I believe, right? Maui? Can't give you any more information than that. But she's like you, watching our surgeries, and decided she wanted the very best. So she came to Deuk Spine from Hawaii, and here we are, doing her surgery. She said her back pain is gone. We did her laser surgery on, what day was that? Tuesday? We did her laser on Tuesday. She has no more back pain. She's so happy. And now we're doing her neck, but for a different reason. This time we're doing her surgery because she has spinal cord compression, nerve compression. All right, we're going to get this suture out tomorrow, leave it in tonight, and she'll be draining some blood tonight, which is fine. My blood loss, I'll call 45 cc's. Thank you, everybody. I'll put the staple. You want to? I'll do this. Can you? All right. Luis will do the staples. Thanks for joining us. We're going to put some staples in. You know how to bring the edges together nicely. And as far as the, let me have a scissor, the hardware we used, you have kept track of it? Hi, Jordan. Someone was asking about you. I think they're an X-ray tech themselves. All right, we got one more surgery today. Yeah, we did. One more surgery later today. You got it? Look how beautiful that is. It's going to come together nicely because all the tension is off the skin edges. It's going to heal beautifully. Thanks for joining us. We'll be back in about 45 minutes to an hour. And we got a laser surgery for you on the schedule. Have a nice day. And good morning, I'm Dr. Deukmedjian, CEO and founder of the Deuk Spine Institute. I'm here with one of my patients who traveled from California with a problem in his neck. He's been having pain, it radiates down into his left arm. He has some other issues as well, like pinched nerves in the elbow and palm, which he's treating in California. But the herniated discs at 5, 6, 6, 7, we did the Deuk laser disc repair yesterday. You can see me going in with the endoscope and the laser. It's all done with a 4mm incision, bloodless surgery, and outpatient. And here he is less than 24 hours later, and he wants to share his story with you. So go ahead.
Okay, so the first thing I want to do is give Dr. Deuk a joke that I wrote last night. He's going to understand this. We might have to look some of these things up. A neurosurgeon was performing several radiofrequency ablations on patients when he started hearing loud shouts and screams in the recovery room. Shocked, he walked into the room to see what happened. The nurse ran up to him. "Doctor, things got pretty heated up for a while, but no one had the nerve to say anything." That one over there seems especially nerveless. All right, so I got him to laugh.
I like
Good stuff. Okay.
I like it.
You know, just a little
Nerveless instead of nervous.
humor there. Good
I love
stuff.
it. I love it. I love it.
What happened for me was ever since I was a kid, I was the young kid that fell off the high chair when I was 2 years old, fell down the staircase when I was 4, got tripped, hit the back of the sandbox at 6. I went in the military. I parachuted out of planes, hit my head more than once with a Kevlar helmet, then served in the military wearing Kevlar helmets, sometimes banging my head against heavy artillery pieces. Sometimes I didn't have my helmet on. Sometimes just the weight of the helmet was hurting my neck and my back.
That part about banging your head in the plane against heavy artillery pieces, sometimes you hear in the military like a helicopter went down, right? Suddenly exploded, went down. Now I know why.
Well, I mean, people will say, why would you jump out of a perfectly normal airplane?
Right.
But, let me just tell you, low contour flying by a sea, some of the jets there makes things a little bit tough. And then after that, what I started to notice, I started to develop where my muscles in the back just became really severely tense and stressed out. I kind of thought it was work and otherwise. And then when I'd go to things like the dentist and I'd lean my head back, my entire left arm would just start tingling and sparks shooting out like crazy. And when I got back up, things were better. But then I went on a trip back in early May, and then it was happening all the time. At that point, I got an MRI done. Obviously at that point, I went to my primary care and I had options. There were 5 options really, if you think about it. One was do nothing, just, hey, I'm getting older, just deal with it. Stop being a baby and just, life goes on. Number 2, maybe seek physical therapy or chiropractic care, which I did, and it helped. For some things, I had really bad posture. That was one of my issues, but it wasn't taking away the problems that I was having with the tingling doc. So then I started to seek out medical expertise in Los Angeles. First choice was full disc replacement for both of the discs. The way I was thinking about disc replacement was, it's kind of like having a car. The tires are halfway worn down. You're having problems with one of the tires in the back, and you decide to replace it with a bigger tire that's different tread, different braking system. Now, it's gonna work if you're riding on a regular road or highway, but it's something different and that's working there, and it was never made for the car.
You'd be replacing it not with a different tire, but a metal tire.
Yeah, a metal tire, even worse,
like
exactly.
a tank tread.
Yeah, and then you can't do MRIs, or you gotta find the ceramic one, which you can. Okay, so that was disc replacement. That didn't sound attractive. ACDF, I've got some dear friends that have done ACDF. Problem there was, I was thinking of that same car analogy. Now you got the rear tires are locked in. They only go straight. They brake at the same time. The suspensions are the same, and only the front 2 are moving around. And I was worried about what is the effect on the disc above and below. And my mom had this problem. She had lumbar fusion with rods in her back, and then she ended up having lumbar fusion in the upper ones when she was alive, and that poor woman went through a lot of pain for it. So I was figuring, hey, look, I'm a guy that works in technology. There's got to be a better solution to this. And I just started doing research online. There's got to be someone. And I was very grateful that I came across Deuk, a spine clinic. I must have watched about 15 of his videos. I started to watch some of the procedures before I started freaking out, just looking at that stuff, just not my thing. I'll stay in technology. But one of the things I found immediately that endeared me to me, Dr. Deukmedjian, was the people that sat in this chair. You could just see what he was doing and how he was helping them. And I knew I'd found the right person that could help me. It was that easy, Doc.
Awesome. Well, you persevered. You were uncompromising. You wouldn't settle for what you were being told, which is, let's go in and put metal in your neck. And we've talked about this. You're aware that there's a big problem in spine with the industry that produces metal pushing these implants on the patients through the surgeons. The surgeons are the ones that recommend it, and the surgeons are rewarded financially in several ways for doing that. Problem is, it is not the best treatment. It used to be the best treatment, but now we've made progress. We do the laser surgery. That is the best treatment, and you've had it. I told you before surgery, it may not work because you got some bone spurs, but you told me this morning that you don't have that pain anymore.
Yeah, I do not. And I can't even describe it because it's a sort of an ease that I haven't had probably for more than 10 years, Doc, at least. I don't even know how long I've been dealing with these, and again, the electroshock and everything else. It's been a blessing, and I'm certainly having you take care of me. And I'll tell you what, Doc, one of the things I'm going to try to do is see, what can we do with the government? I mean, it doesn't matter what side of the aisle you're on, but maybe there's ways to talk to folks in the government to get more attention to these kinds of things. Because what I'm afraid of, I found you because I looked really hard and I did all the research. There's a lot of wonderful people out there that they just don't know. They're really limited on their options.
Of course. The problem is the absolute truth, which people don't want to hear, is the government is controlled by big business.
Yeah.
And there is no business in the world bigger than insurance companies. They are the most powerful. They've brought the pharmaceutical industry to its knees. They've brought the medical industry to its knees. And the insurance companies just sit in the back. They take your money every month with premium payments, and then they don't pay their bills. And they keep the money and then become richer and richer and more powerful. The insurance companies do not want my surgeries out there because they work. and they know what's going to happen. Everybody is going to want it. And that is going to be like, what do you call it? A run on the...
Yeah, run on the market kind of thing. Exactly.
Yeah, everyone's going to want it. They're going to get all these bills, and they're going to have to pay them, and it's going to be in the center of attention. All these people are going to be complaining they're not paying the bills. Insurance companies do not want new technologies that work. They want patients to only have old technology that doesn't work, that they're afraid of, because there's nothing better for an insurance company than a patient who's scared to have a medical treatment. The patient won't get it done. There won't be a bill for the insurance company to pay. They get to keep the money, and they don't have to be the bad guy denying payment.
Yeah, and Doctor, you were saying also that overseas folks have embraced technologies like what you're able to provide, right?
That's correct. Yeah, if you go to China, India, Korea, they don't do much fusion. They do mostly endoscopic surgery because it's better. And in the United States, there's only probably 5 surgeons in the whole United States that do true endoscopic surgery. Some of them advertise it, but they don't actually do it. A lot that needs to happen. We're probably 30 to 50 years ahead of the rest of the spine surgeons out there in terms of treating spine issues that are degenerative and joint issues that are degenerative. But I appreciate you sharing your perspective.
Thanks, Doc. Appreciate it.
Thank you
Thanks so
sir.
much.
Congratulations.
All right, appreciate it. Thank you.